Good morning, everybody. Thanks to CN and IWBNC for the opportunity to share this e-poster titled Outcomes After Intraoperative Electrophysiological Resolution of Hemifacial Spasm. Hemifacial spasm is a rare condition that usually affects mid-aged females and causes important functional, cosmetic, and societal issues. This is described as a transient or persistent facial contraction that usually starts at orbicularis oculi muscle and spread over years to other facial muscles. This is a non-physiological spontaneous discharges that occurs at the facial nerve, and this is the origin of abnormal facial contraction. It's important to differentiate primary cases due to neurovascular compression and secondary cases due to CPA tumor, for example. The first line treatment in hemifacial spasm is the botulinum toxin injection with a high rate of success. Medications are reserved for medical refractory patients and not suitable for surgery. And finally, microvascular decompression surgery is a second line treatment as effective as botulinum toxin injections in medical refractory patients. For this case report, we describe the clinical features, intraoperative findings, electrophysiological monitoring, and outcome in a patient with medical refractory hemifacial spasm. And then a literature review concerning outcomes after intraoperative electromyography resolution of hemifacial spasm was accomplished. A 63 years old female with a left hemifacial spasm 7 years ago was treated with a high ascending dose scheme of type A botulinum toxin with a decrease in the clinical effect over years. In the MRI axial imaging, a left pica compression over facial nerve transition zone was identified and a microvascular decompression surgery was indicated. A keyhole retrosigmoid approach was performed, and during surgery, a type E neurovascular compression from pica and its branches and a huge membranes around the nerve were identified. After dissection and decompression, a Teflon patch was interposed between the nerve and arterial structures to avoid direct contact. In this video, we can see free cisternal facial nerve segments and pulsations from the arterial structures away from the nerve. Intraoperative electromyographical monitoring identified abnormal muscle response in frontalis, oralis, and mentalis branches of the facial nerve in both free and stimulated electromyography. And after microvascular decompression, disappearance of abnormal muscle response was obtained in the same branches. And after 1 year follow-up, a Japanese grading E, C, and T0 was achieved. Based on the literature, the proximal cisternal anatomy of the facial nerve can be divided in 4 segments, being the attached segment the most common location of the neurovascular compression, followed by the transition zone, also called Obersteiner-Radlich zone. Regarding imaging, although greater than 20% of normal subjects have vascular compression on MRI, the findings are significant only in patients with symptoms in the affected site. The most common vessels offending the nerve are ICA, pica, vertebral artery, and less frequently veins. There are 6 surgical patterns of neurovascular compression described by Park and colleagues and are important to know in order to standardize the report in surgical cases. The overall spasm freedom rate after microvascular decompression surgery is near to 90%, which is a high rate of success. However, spasm freedom is more likely after an initial surgery in comparison to an reoperation. Importantly, there is no significant relationship between spasm freedom versus persistent spasm, age at surgery, timing of follow-up, gender, disease duration, site of disease, or vessel type, which support microvascular decompression in almost any kind of patient. In a meta-analysis developed by Sand and colleagues, the disappearance of abnormal muscle response during microvascular decompression surgery demonstrates limited prognostic value for a favorable short-term outcome, with a low relative risk, with a lower limit close to the unit, and does not appear effective in predicting the long-term outcomes of patients with hemifacial spasms, with a relative risk at both sides of the unit. As a take-home message, patients refractory to medical therapy are well suitable for surgery. Intraoperative electromyographical monitoring could increase the safety of the operation and improve outcomes, but are not a guarantee of success. And importantly, delayed relief and recurrences are also possible, so close follow-up are advised.